It's okay. Okay. So good morning, my dear guest. It's truly my pleasure to present here at Saudi Liver Meeting 2025. I would like to begin to thank Dr. Mohammed Shagrani for inviting me to be a speaker, and he gave me the opportunity to be part of this inspiring scientific gathering and and thank you for the organizing committee as well. Today I'm going to share our experience with HLH, secondary to influenza infection, in pediatric population, highlighting the key distinguished challenges, management approach, and the outcome of our local series at King Faisal Specialist Hospital and Research Center. Okay, so it's not moving. Okay. So secondary HLH is a hyperinflammatory syndrome. Influenza is a documented but rare pediatric trigger. The core for this phenomena, patient present with fever, cytopenias, hyperferritinemia, organomegaly, high triglyceride, and decreased fibrinogen level with hemophagocytosis documented in bone marrow examination. This patient will present with shock. Multi-organ dysfunction is common in BICU. So what is the pathophysiology behind this, and why influenza can trigger HLH? Actually, there were 5 explained mechanisms of this. So influenza usually will derive a cytokine storm biology by secreting interleukin-1, 6, and interferon gamma with a tumor necrosis factor, tipping toward macrophage activation, mechanistically aligned with HLH and macrophage activation syndrome. So the first explained pathophysiology is excessive immune activation. So influenza, both A and B, is a potent viral activator of the immune system. Viral antigens will stimulate cytotoxic T lymphocyte and NK cells. In HLH, there is a defective cytotoxic function. So due to genetic mutation or transient immune dysregulation, so instead of clearing the infected cells efficiently, immune cells will keep secreting cytokines. This will lead to cytokine storm, uncontrolled release of these factors, interferon gamma, tumor necrosis factor alpha, and interleukin-6, 10, and 2, which is CD25. The second explained mechanism is defective viral clearance. So normally, NK and cytotoxic T lymphocyte kills the virally infected cells via perforin and granzyme pathway. So in HLH, whether familial or secondary, there is a defective or overwhelmed cytotoxicity. So influenza-infected cells persist, leading to chronic antigenic stimulation and then sustained macrophage and T-cell activation. The macrophage will be hyperactive. So influenza virus can directly activate monocyte macrophage by producing toll-like receptors, through toll-like receptors. So hyperactivated macrophage will start hemophagocytosis, so engulfing the blood cells in the bone marrow, spleen, and liver. That's why these patients present with cytopenias. There are some patients actually with who have an underlying predisposition compared to the other kids by having an existing mutation which is silent till they are hit by a viral trigger like influenza, so unmask their HLH presentation. So even without primary HLH genes, influenza can cause secondary HLH phenotype in otherwise immunocompetent children. So diagnostic criteria for HLH, actually we follow the 2004 diagnostic criteria, which is, as we see here, fever with a splenomegaly, cytopenias, at least 2 or more of the cell lines will be affected, hypertriglyceridemia or hypofibrinogemia, hemophagocytosis documented in bone marrow, spleen, and lymph nodes, but it's not necessarily to be there. Low or absent NK cell activity, ferritin. Actually, in HLH, usually the ferritin will be more than 500 nanogram per ml, but actually we notice in the cases with HLH secondary to influenza, usually the ferritin will be more than 10,000. Elevated soluble interleukin-2 receptor, CD25. So when to suspect HLH in severe influenza? So if a patient you are admitting him with an influenza infection and he has a persistent fever despite well coverage by Tamiflu and antibiotics, and by a patient who is having bicytopenia or pancytopenia, always do a stat ferritin level just as a baseline. And you will see the ferritin very high with high triglyceride, a low fibrinogen. Fibrinogen can be initially high and then start to go low. Hepatosplenomegaly with coagulopathy. If the patient he was having influenza progress into multi-organ dysfunction, including liver, kidney, CNS, always think of secondary HLH. So what do we have existing in literature describing influenza-induced secondary HLH? So actually we have only few case reports have been reported since 2004 with few cases. So the first case was explained in an 8-year-old child who was previously healthy, presented with prodromal viral symptoms, and she was tested positive for H1N1 influenza. She had a rapid deterioration, progressed into multi-organ failure. So this patient, due to persistent fever, her CBC showing cytopenia and low white cell count and platelet with hepatomegaly, her ferritin was high, hemophagocytosis in bone marrow. The outcome for this case was fatal despite aggressive management because she was recognized too late at the time she had multi-organ involvement. The second case was also reported from Japan with influenza B triggered HLH in a 4-year-old child with the same classical presentation for HLH. And this patient actually, she was a bit late, however, she was still, she received treatment for HLH, including, actually they were following the treatment which is mentioned in the guideline for 2004, etoposide and dexamethasone. Patient had supportive care and viral management. This patient actually, she had a very severe course with a prolonged ICU admission. However, she had a full recovery. The third case was in US with an influenza B as well, ARDS, in a 9-year-old child who had same high fever, progressive respiratory distress, and she progressed into ARDS with cytopenia and high ferritin level with triglyceride. So this patient also was managed with the same HLH-directed therapy and clinical outcome. She improved after HLH-specific therapy. So what do we have in our local experience 2025? So for the first quarter of 2025, because why I'm telling that? Because now we have, again, we have started to have similar cases. So we had 4 pediatric cases of influenza-triggered secondary HLH. Multimodal therapy actually have been required for these cases, including IVIG, steroid, cytokine blocker, organ support, including CRRT, plasma exchange in severe and fulminant cases. So let's begin with our first case. So this patient was referred to us from private hospital on 13th of February 2025 as a case of acute fulminant liver failure with worsening encephalopathy, presumed to have secondary HLH and cytokine storm triggered by influenza B pneumonia. This patient was transferred to us for advanced workup plus minus liver transplant evaluation. So this patient, prior to admission, she had typical prodromal viral symptoms. She progressed with being drowsy, hypoactive, admitted on 10th of February in the referring hospital as a case of influenza B pneumonia with gastroenteritis. 3 days after admission, she progressed with sudden severe abdominal pain and encephalopathy. At that time, she was referred to us, and if you can see her lab work when she came to us, you can see on 13th of February, she had very high liver enzyme, including AST and ALT of more than 7,000. She had as well, if you can see, coagulopathy with the highest INR reaching 5 in the referring hospital with low fibrinogen and high D-dimer. As you can see, it was 18, the D-dimer upon presentation. Her ferritin level was 35,000 on admission with very high interleukin-6 reaching even up to 240. With bilirubin being elevated, but it's not proportionate to the degree of the liver involvement and severe encephalopathy and coagulopathy that she had. This is a very important point. So this patient, when she arrived to BICU, we started her on CRRT as she was encephalopathic. She had 3 sessions of plasma exchange as she was severely ill, just an idea to wash cytokines. and to minimize the risk of bleeding using FFB as the mainstay of volume exchange. She received the 2 doses of IVIG, methylprednisolone of 30 milligram per kg for 3 doses, and then she received also tocilizumab, which is considered as an interleukin-6 inhibitor. And then she was transitioned to dexamethasone and anakinra as a maintenance. Luckily, this patient, despite she was really sick, she had a full recovery, and she's doing perfectly well. The second case that we had, a male who is 17-month-old, he was extremely mature of 26-weeker with a prolonged NICU admission. Otherwise, he was healthy after that. So he was referred as a case of fulminant liver failure, encephalopathy. He has a documented influenza B infection with severe systemic inflammatory response and cytokine storm. So this patient was sick with encephalopathy, ARDS required to be intubated with picture suggestive of cytokine storm, as you can see in this presentation. So this is his labs. He had almost similar with a very high ferritin. Actually, ferritin was 7,000, but prior to coming to us, it was higher because he was initiated treatment there in the referring hospital. So he had also bicytopenia with low platelet and white cell count. His INR, the highest one was 3.5 in the referring hospital. This is afterwards, after he received blood product. And his bilirubin, as you can see, wasn't much, was normal actually. So he was supported with the same almost by having methylpred IVIG, and he showed a marked improvement with full recovery. The third case, an 8-year-old, was also premature of 28-weeker, one of the twin. She had also prolonged NICU admission for almost a year, was oxygen dependent, but however, she was off oxygen, she was doing well. She was referred also with the same presentation, a case of fulminant liver failure with severe systemic inflammatory response for possible plus-minus liver transplant. Actually, for this patient, unfortunately, she came to us very late. She was 48 hours prior to transfer to us, was encephalopathic with GCS of 3 and 4 without any sedation. So when she came to us already, she had severe brain edema with a brain insult. Unfortunately, despite aggressive care and management, she died. The fourth case of a 2-year-old female with no significant past medical history. She was referred for management of secondary HLH. She had also anuric AKI, suspected to have hemolytic uremic syndrome. So for this patient, she presented by almost mid-January 2025 with viral illness, bloody diarrhea, diagnosed to have HUS, started in peritoneal dialysis for anuric AKI. Her bone marrow aspirate confirmed HLH secondary to influenza. She had influenza A pneumonia, progressed into respiratory failure and intubation. She had the cytokine storm, HLH flare, treated with IVIG 3 doses, pulse steroid for 3 doses, and then she switched to dexamethasone. She received tocilizumab, interleukin-6 blockade, 2 doses, and she received ravulizumab for her HUS. And this patient also, she had full recovery. So in summary, influenza in general can precipitate fulminant liver failure, secondary HLH in pediatric. Hyperinflammatory markers, ferritin, interleukin-6, D-dimer are crucial diagnostic clues. Early cytokine targeted therapy, steroid, IVIG, interleukin-6 or interleukin-1, either tocilizumab or anakinra, may prevent irreversible organ damage. Multidisciplinary critical care hepatology coordination is a key. So management timeline for this patient, stabilization, always airway hemodynamics by BICU team, and then starting early antiviral therapy. In a patient who has a persistent fever, even if he is in your center, start pulse steroid as early as possible with IVIG till he is getting the acceptance and transfer to a transplant center. And then organ support for a patient who are encephalopathic, regardless of the ammonia level, to be initiated on CRRT with plus-minus plasma exchange in severe fulminant cases. Cytokine blockage, either anakinra or tocilizumab. So take-home message, HLH should always be considered in severe influenza with persistent fever, cytopenias, and high ferritin level. Early recognition is matters. Ferritin and basic labs are key for timely suspicion. So do a ferritin level in a patient who is admitted with influenza infection. So a unique local observation. In our cohort, the degree of hyperbilirubinemia, as you saw in the previous slides, was not proportional to the severity of coagulopathy and encephalopathy. So most cases had normal or only mildly elevated bilirubin despite significant liver injury. Aggressive multimodal therapy is often required, IVIG, steroid, cytokine blocker, and organ support. Mortality remains significant, but early suspicion and comprehensive care can improve the outcome. So these are my reference, and thank you very much.
Thank you very much, Dr. Samah. You can stay for questions, please. Thank you very much for a wonderful presentation. We're going to give, and thank you for staying on time. This is wonderful. We can give like 2 minutes for questions. تفضل دكتور محمد.
Thank you for a wonderful talk. My main question is, how do you decide which cytokine blocker to use? Because you have anti-IL-6, anti-IL-1, and you can even advance it even further. You can go with anti-TNF like emapalumab. So how do you decide? Do you send a cytokine profile, for example, and then based on what levels are elevated, you decide to block these drugs or not?
Actually, this is what we have done. Most of the cases, actually, there is in a patient who has significantly elevated interleukin 6, like 400 plus. There is no definite number, actually, exactly which to decide. We're consulting our colleague in hemato-oncology, and most of them, they're worried to use tocilizumab in a patient who has severe liver involvement, as it might also lead to hepatotoxicity. So the most severe case that we have, we started initially with tocilizumab, and she received 3 doses. But we cannot say like 100% whether she improved because of it, because after 3 doses, we switch her to anakinra. So exactly, we sent only for interleukin 6 level. Dr. Muhammad, maybe he will add something.
So if for Ayub, actually, the most important points here, I mean, it's not easy to have a patient acute liver failure, then you will not push him for transplant. You will say this is cytokines. But we learn here, how many times you will see fulminant liver failure with liver enzyme more than 6,000, lactate more than 10, and the bilirubin is just mildly elevated. There is none. And the other things, we have the facility to have the interleukin 6 very quick. So whenever you have very high interleukin 6, very high serum ferritin, you know that the INR and the lactate is a pathway more than to be a real liver hepatocyte damage. And this is the way. So tocilizumab is the drug of choice. If you don't have, you can start anakinra. But the most important, the plasmapheresis, the steroid immunoglobulin, because you wanted to block everything in the interleukin by blocking B cells, and then you work for maintenance. And usually you have a very short window, 2 to 3 days maximum if you will not act. But I wanted to tell you the truth. At the same time, we prepare a living liver donor. We were working on the transplant side, having a backup donor ready. But I'm totally convinced those patients, if you will take them to the OR, they will die. They will die intraoperatively. And unfortunately, we have a case admitted last night, the same scenario. So we were in the ICU last night, Dr. Ahiba is on call, and the patient now in the same protocol. He came with INR 7, lactate more than 10, liver enzyme 1,000, and the bilirubin 80. We did the interleukin 6, came yesterday to be 470. So he started on all the management and all the numbers today showing very good improvement. It's having coincident at the same time of the talk.
Can we just add, but there are children who got really well transplanted while they had this fulminant picture. So my question is probably, if you actually give them the liver transplant immunosuppressive protocol, would that change their natural history? Because if you transplant them, there are children who got transplanted, and there are children who got away with it. And we understand if you just put a new liver there, the cytokines will overwhelm the new liver. Perhaps that's not the point. Perhaps the point is that these children receive the liver transplant immunosuppressive protocol, which switches off their immune storm. So if we adopt the liver transplant immunosuppression protocol in these children without liver transplant, what are your speculations? Do you think they will get away with it?
Yes. Yes, that's a very intriguing question. It may indeed be true that in transplanted children, you set off the ongoing hemophagocytosis. However, I think now knowing it, like you beautifully illustrated, knowing better the pathways and having now for the first, only a relatively short, last 5 or 10 years, you have specific ways to mitigate the pathways. I think we can do better, more specific in the pathway management than just a general post-transplant steroid and immunosuppressive regimen. I think it does work, but most likely, particularly if you have the cytokine profile available, you can perhaps even improve the gain of it. But the idea is correct. And we met transplanted children that we turned off the ongoing problem by the immune suppression. That's absolutely correct.
Thank you very much. Do we have time for one more question?